Hello, hi there, and we are talking right now about the third part of the myasthenia gravis. This disease is rather systemic. It's really a syndrome, and management has a lot of debates and changing. As we mentioned before, in myasthenia gravis, the surgery is a debatable option because some patients did not improve after surgery. The surgery of thymectomy is really should be discussed with the family, so they will have a long-term opinion about what will happen to the patients. As we mentioned before, some patients after surgery they have decrease in the dosage therapy. Some patients they have a period free time, and some patients have no change in their course of the disease. Indeed, we have seen many patients in the intensive care unit with myasthenia gravis and history of surgery thymectomy in the past. And as you can see, the surgery approach for this patient is it really sternal sternotomy. You'll do it vertical or horizontal, and here is the posture of the patients. The third approach, you can do the VATS, video assisted thoracoscopic surgery for the patients. The video approach, also they can go substernal or suprasternal approach, but we have to learn or have to know that the laparoscopic approach is longer. It will sometimes take more than 6 hours for the surgery, but they have a minimal scar, etc. Okay, and that is really, as you can see, the surgery thymus gland apparatus after surgery. How does it look after resections? This really a very faint, beautiful surgical resection of the thymus gland. This is really a rather beautiful resections. And here is my picture again in the winter with fantasy, thinking about the cold weather. Okay, now in general, we have to mention that there are strong indications for thymectomy at which really should encourage the neurologist to refer the patient to the thoracic surgery. Number one, presence of thymomatous myasthenia gravis. So if there is a larger thymoma for the patient, it's really a good indication. Number two, symptomatic non-thymomatous seropositive myasthenia gravis. Seropositive myasthenia gravis. So they have acetylcholine receptor in their body. So we mentioned that 85% of the patients they have positive acetylcholine receptor antibody in the circulations, and those patients really prefer to have surgery. Number three, refractory myasthenia gravis. Refractory, not responding to medical therapy, so they need surgery. Number four, presence of any degree of thymoma. Number five, presence of suspicion of thymic carcinoma. And number six, recurrent myasthenia gravis following a previous thymectomy. And that was really a rather difficult one to discuss, So indications for thymectomy in patients with myasthenia gravis is thymomatous myasthenia gravis, symptomatic non-thymomatous seropositive myasthenia gravis, refractory myasthenia gravis, thymoma, thymic carcinoma, and recurrent myasthenia gravis. Okay, thymectomy should be done. Thymectomy really should be rather early than late if it will be done. And it was the previous surgery in history. The first surgery of thymectomy was done 1913. So surgery has better result if done at younger age. Surgery has better result if done at younger age. In the early course of the disease, 50% of the patients will improve within 2 to 3 years after thymectomy. 50% of the patients will improve within 2 to 3 years after thymectomy. Now, let's remember that 25% of the patients after surgery, they will have a medication-free remission, while 50 other patients, they have significant reduction in the medication therapeutic dosage, significant reductions, but in 25% of the time, the patient will not have any improvement after the surgery. So this is a very common question for exam, you know, what is the success rate of the surgery? So it will be like 75% of the time there will be 75% there will be benefit. 25% of the time there will be no benefit. Here is another debate. So all patients with seropositive generalized myasthenia gravis should have thymectomy early in their life, regardless of the size of the thymus gland. Here is a good debate. All patients with seropositive generalized myasthenia gravis should have thymectomy early in their life, regardless of the size of the thymus gland. Some people is against, some neurologists is really against this. They said, no, the size is important. I will do CT scan, I will assess, I will discuss, etc. You know, but some people, they prefer the surgery in a seropositive patient. That's really our debate of discussions, and it's very nice. That's what I like the approach in the hospital, is that you really create a consult team from neurology, neuro-ophthalmology, internal medicine, thoracic surgery, oncology, and discuss the case. Why not? Why not to have a group of people sit together, review the history, especially those people who are really experts in the disease, to discuss the case, and then we'll take it from there. Okay, now here is a very important point. Debate. Intubation. You have a patient. My patient, the one who was a driver, truck driver, he went to the ICU. Second day in the same night in the ICU, he developed respiratory distress. So when to intubate patients, you know, let me tell you, patients with myasthenia gravis, they have oropharyngeal weakness, they have respiratory muscle weakness, sometimes they get fatigued, their CO2 will rise, and they will have slowly growing respiratory distress, and until they will get so hypoxia is a late phenomenon. Hypoxia, indeed, CO2 retention, drowsiness, and decreased level of consciousness happens first. Hypoxia happens late. So criteria for respiratory failure, you know, because this is a slowly growing disease, the CO2 will rise and rise, like many other neuromuscular disorders. So when to intubate those patients? When to intubate? If they got confused, if they got decreased LOC, if their CO2 reached to a different number or something, etc. So that's a point of debate. And this one really is an interesting point. Well, it's a clinical gesture. So indeed, what I believe, in my personal opinion, and maybe some people will disagree with me, is that if you have a myasthenia gravis with respiratory distress and fatigued patients, you know, you'd rather intubate them and initiate plasmapheresis 2, 3, 4, 5 sessions until the patients improve, and then extubate them, and not the other way around. You know, my patients, I remember he had confusion, he was restless, he was combative, you know, and then because of the respiratory distress, and then we have to intubate him. We have to intubate him at the end, you know. Criteria for intubation is a matter of debate. When to intubate? Shall you initiate plasmapheresis before or after, you know, etc., you know. Another question, the people will say non-invasive versus invasive. No, BiPAP is usually for short-term diseases, you know. If you think that the crisis will take few days, you know, it's better to intubate patients. You know? Some people, the myasthenia gravis really resolved in few days, and some people the crisis will take a longer time. So BiPAP, in my opinion, is out of discussions. It's better to intubate or not to intubate. And here is a protest. You know, says that please, you know, doctors, they make mistakes. Tired doctors, they make, because we are human, guys. We are human. That's why we are mistakes. We are not robot. We are not RoboCop. and we are not automated machines. We are human. Of course that doctors will make mistakes. Please give them less on call. Please just take mercy. Some people, they work for 36 hours, etc. in the hospital. How come a doctor works 36 hours with no sleep in the hospital, and then you put them in investigations if they do mistake? Come on, this is very inhumane. Okay, so another debate: resuscitation. What therapy shall you initiate for those patients? What therapy, you know? Which is number one drug? Which is number two therapy? Which is number three? Which is number four, you know? So, the neurology, CTU, intensive care, combination therapy is a matter of discussion. Okay, plasmapheresis. And then you give them, for those patients, IVIG, immunoglobulin, 400 milligram per kg. So, which to start first? And if you start plasmapheresis, how many sessions? 1, 2, 3, 4, 5, etc. And then some people, they believe that you do plasmapheresis until the patients improve, until you get a clinical improvement, even if you give them 12 sessions, 14 sessions, you know. And some people, they said, I'll give them 5 sessions and then reassess. Another 5 sessions and reassess, you know. So, cocktail, and immunoglobulins, you know. What will you initiate? Which one? This one or that one? Steroid, high dose steroid. You know, is it the first line, or is it the second line, or whatsoever? So this is a matter of debate. Okay, and then later on you initiate, after plasmapheresis, IVIG, high dose steroids, you initiate anticholinesterase inhibitor. Later on, you initiate anticholinesterase inhibitor. Okay, later on initiate anticholinesterase inhibitors. You know, so advanced therapy for myasthenia gravis is the immune suppressive therapy, aggressive immune suppressive therapy, as a thiopurine, methotrexate, you know, MMF, cyclosporin, and tacrolimus. Okay, so this is for the refractory patient, not responding, you know, you give them anticholinesterase inhibitors, they are not responding, and then you are obligated to choose another immune suppressive therapy. Those patients, the difficult myasthenia gravis cases, those cases really, they deserve admission, discussion, consult, etc., and the discussion for the patients. And look at the CT scan here, you know, done for our patient. Remember, the patient does have severe mediastinum, and very nice radiologist who told us, guys, there is a widening mediastinum, we have to do a CT, this and this, and I went down to the radiology department. I met my colleague, you know, we have a nice discussion about this one, and he told me that you have to proceed for thoracic surgery discussion. Okay, so it's very nice to admit those patients to the intensive care unit, especially if they have any symptom signs of respiratory distress, for the query intubation precaution, and you have to give them full supportive therapy, initiate plasmapheresis and corticosteroid, high dose corticosteroid, and you take it. Okay, so a debate is, let me say again, a debate: when to intubate those patients, when to start their supportive therapy. This is really a matter of debate. Anyhow, we should really give them the... Now, there are so many options in the myasthenia gravis, so many options, but I will tell you the summary consensus. The summary consensus of management in myasthenia gravis. Please listen to this terminology. Please, regardless of your opinion, regardless of your management, regardless of your institute, please remember to these strong consensus recommendations. Number 1, pyridostigmine should be part of the initial therapy for all patients with myasthenia gravis. Number 2, non-steroidal immune suppressive therapy. Immune suppressive therapy can be used in myasthenia gravis, including azathioprine, cyclosporin, MMF, methotrexate, and tacrolimus. They are equal. You can choose any. Number 3, plasmapheresis and IVIG are equally effective, are appropriate. Both are equally appropriate and equally effective short-term management of myasthenia gravis with life-threatening sign. Number 4, immunoglobulins and plasmapheresis are equally effective in the treatment of impending myasthenia crisis. The expert consensus suggests that plasmapheresis is more effective. Plasmapheresis is more effective than the IVIG and works more quickly than the IVIG. Plasmapheresis is more effective and works more quickly than IVIG. Finally, look at this. In children, what shall we do for kids with myasthenia gravis? Will you do surgery or no? The consensus say that in children with non-thymomatous myasthenia gravis, they have no evidence of thymoma in CT scan. Thymectomy should be performed as an option for those patients to minimize the dose or the duration of immunotherapy. Okay, as an option and discussion with the final point. The value of thymectomy in the treatment of pre-pubertal myasthenia gravis in kids. Pre-pubertal myasthenia gravis is unclear. But really, the recommendation says that thymectomy should be reserved for kids with generalized myasthenia gravis and seropositive serology and seropositive entity. So generalized myasthenia gravis with a seropositive pattern, they should have this one. Maybe you may consider this one. Thank you very much, guys. That's the end of discussion of very interesting, challenging topic of myasthenia gravis. Here is my picture in the winter again, enjoying the cold weather. Thank you very much. See you again.